Hi guys, this is a quick review of lecture 13 for Physio. I might tack on lecture 14 at the end of this. We'll see. Changes in the reproductive system throughout life. So we have changes in the production of LH and FSH, how much is being released, and it gets pretty interesting, right? Because we're dealing with gonadotropin releasing hormone, FSH, LH, then testosterone and estrogen. So we have the different stages, and we're really concerned with puberty and the changes brought on at that point. So puberty for us was defined as, for boys, this typically occurs between 9 and 14 years of age. For women, 8 to 13 years of age. It's driven by two processes. The first is, I'm going to mispronounce this, adrenarche, which is maturation of the adrenal cortex, and it's associated with an increase in the secretion of adrenal androgens. So we're going to have this dihydroepiandrosterone, DHEA, and then dihydroepiandrosterone sulfate, DHEAS, and then androstenedione. And so basically the first of these two processes that are signifying puberty, this one's going to lead to the development of pubic hair. Then we have gonad arc, which is the growth and development of the gonads. So we have adrenal cortex changing, and then we have the gonads maturing. And so this is going to lead to increased secretion of estrogen and testosterone. We, of course, know that the testes and the ovaries are producing estrogen and testosterone. And so for gonad arc in females is going to be initiation of folliculogenesis, which we're very familiar with, right? We go from primordial follicles all the way to our secondary Graafian follicles. Ovulation, very familiar with, and then thelarch, which is breast development. And then in men, we have testicular enlargement with onset of gonad arc, and then spermatogenesis. All right, so then we have mentioned with the onset of adrenarche, we have pubic hair, and then gonad arc is development of secondary sexual characteristics. So these genital and pubic hair changes are classified into 5 stages called Tanner stages. And it's really class 2 that we're going to be concerned with. This represents the onset of our 2 changes in puberty, adrenarche and gonad arc. So the onset of puberty, these are the Tanner stages in females. So this is stage 1, prepubral, no pubic hair. Stage 2, you have a breast bud and papilla elevated, small mound present. There's so this is talking about the breast, and then slight growth of fine hair right here. Again, this is the onset of puberty, stage 2. Then you have enlargement of the breast mounds, some palpable glandular tissue in there, continued growth of the hair, and then stage 4, the areola and nipple are elevated, and then more hair, but less area covered, and then finally adult breast and even more hair. All right, so it's really stage 2 that you need to know, which is the formation of the breast bud, the start of growth of hair in the pelvic region, and that would be the onset of puberty. So for men, it's fairly similar. You have the enlargement of the penis, and then secondary characteristics of androgen, which are increase in muscle mass, change in sound of the voice, vocal cord length, and then facial and body hair. So 1, pre-adolescent, no pubic hair. 2, scrotum and testes enlarge. You might have a little bit of hair starting to grow. Again, stage 2 is the onset of puberty. Adrenarche and gonadarche. Again, adrenarche, release of androgens from our adrenal cortex on top of the kidney, right? And then gonadarche, the maturation of the gonads. All right, so then you can just see as we go, penis, scrotum continues to enlarge, and you have increase in pubic hair. So not too much there. We have the concept of steroidogenesis. So this is something we've, already seen in our histo lectures and the previous physio lectures. But basically, steroids, think testosterone and estrogen, which are going to, work on the development of our secondary sexual characteristics, and they're, we're having them synthesized in the testes or the ovaries, as well as the adrenal glands. And so you can have the adrenal cortex working together with the ovaries or the testes. And so we can have, the same process as we saw previously, cholesterol to pregnenolone to progesterone. We have adrenal cortex will produce cortisol, but importantly, pregnenolone to 17-alpha hydroxy pregnenolone, which can be exported to the ovaries as DHEA, which will get converted to testosterone, and we know testosterone can get converted to estrogen by aromatase, and then we can have 5-alpha reductase work on these guys to give us dihydrotestosterone. All right, so that's not too bad. Then we're familiar with the hypopituitary or hypothalamus pituitary axis, and so we have the production of our gonadotropins, which are luteinizing hormone and follicular stimulating hormone. We know those are both released by the pituitary gland after the pituitary gland receives gonadotropin releasing hormone from the hypothalamus. All right, and so how does that go about? Well, we have these kisspeptin, KISS1 neurons, which activate kisspeptin receptors on the GnRH neurons of the hypothalamus. And so, theoretically, if you recall, we have a pulsile release. So the initiation of our pulse coming from this KISS1 neurons, it's going to cause our GnRH neurons to release GnRH, which will then go to the pituitary and cause our gonadotropes to release gonadotropins, which are our luteinizing hormone and follicular stimulating hormone. All right, and then, it's just a reminder, as we said, this is a pulsatile release every 1 to 3 hours, and it is inhibited by estrogen and testosterone. And then you may recall that for women, the onset of the ovarian cycle, we have a spike in FH, and then on day 14, we have a spike in LH, and this is for women. And so as we, started to say in the previous lecture, we said that this is due in part to the sensitivity of these gonadotropes, which are releasing luteinizing hormone and FSH, to the feedback of, the sensitivity of gonadotropes to GnRH as a result of feedback from estrogen. And so normally our estrogen is doing negative feedback, but and as a result, the gonadotropes are not very sensitive to releasing luteinizing hormone at the beginning of the ovarian cycle. But then as estrogen increases, it goes from a negative feedback to a positive feedback for about 2 days, and it's going to make the gonadotropes more sensitive to gonadotropin releasing hormone, specifically for the luteinizing pathway and result in releasing more luteinizing hormone for like a 2-day period. All right, but for males, we don't have that sort of shift in estrogen sensitivity. At least we weren't discussed, wasn't told to us. We were just told that the pulsatile release of follicle stimulating and luteinizing hormone for males is constant, and for females we do have that surge. All right, but the secretion pattern overall, if you were to take kind of a long view from fetus, infant, pre-puberty to post-puberty, you can see that there's actually a very long period before puberty where you have very little secretion of gonadotropin releasing hormone overall. And then this increases with the onset of puberty, which results in more follicular stimulating hormone, more luteinizing hormone, which we know ends up giving us those two things are going to lead to more estrogen, more testosterone, and therefore this whole process of puberty. All right, so then the development of secondary sexual characteristics. All right, so we said GnRH is pulsatile, 1 to 3 hours every day. And in particular, as we said, it's low for pre-puberty. And then this is just a diagram of the result of the release of GnRH on luteinizing hormone and follicular stimulating hormone. And this is for this diagram's for women in particular, but as we are familiar with from the ovarian cycle, notice how follicular stimulating hormone and luteinizing hormone are offset from each other. All right. Okay, so then control of the onset of puberty. Central dogma is this really all just about the release of GnRH. Our gonad or steroids, we are familiar with how these are made. We have our 2-cell system, so our Leydig cells and our Sertoli cells. And so our Leydig cells are outside of the follicle, if we consider the follicle to be our seminiferous tubules. So our Sertoli cells, our Leydig cells are going to take in LH. They're going to take in cholesterol, and then as a result of the LH pathway, the enzymes that they produced are going to convert cholesterol to testosterone, which then they'll export into the blood from endocrine pathway and paracrine to the Sertoli cells. Sertoli cells will use their androgen binding protein to maintain a high testosterone level inside of the seminiferous tubules. Great. It can also produce aromatase, which will convert testosterone to estrogen. All right, and then testosterone, basically the amount is directly correlated with the stages of puberty and the aging of the bones. In prepubertal boys, secretion of LH and testosterone is related to the random eye movement sleep stage. So you need a lot of sleep for growth. And then during fetal life, which is something we already know from embryo lectures, testosterone is secreted by the testes and responsible for formation of external male genitalia as a result of actually DHT, and then the prostate gland, seminal vesicles, and male genital ducts. All right, estrogen is made by the ovary and for women in the ovaries and the placenta. We have 3 forms. We have estrone with a 1. That's the main estrogen during menopause. Estradiol, which is the main estrogen during the reproductive cycle. Estriol, which is the main estrogen during pregnancy. All right, so made by the ovaries and the placenta. And then main function is the formation of our secondary sex characteristics, regulate the menstrual cycle, right? We know that for the proliferative phase, estrogen is building up that endometrium, the functional layer, promotes bone formation and epiphyseal closure on the ends of the long bones. So with onset of puberty and the increase in estrogen, women stop growing. All right, so then precocious and delayed puberty. Precocious meaning early, right? So early Gonad arc is appearance of, secondary sexual maturation before the lower limit of the normal age in children. And again, what is that? For women, 8 to 13 years old is normal. So if you're before 8 years old, you'd be considered early for puberty. All right, so then central precocious puberty, CPP, is a premature reactivation of the hypothalamic gonadotropin-releasing hormone pulse axis. Again, remember, you have a very long period of basically no release of GnRH. So basically it's just saying this change right here happening early could be is what's going on with central precocious puberty. All right, so it's GnRH dependent, can be considered idiopathic with an unknown cause, or neurogenic, so some brain issue, something wrong with the hypothalamus overall. Idiopathic, you have progressive and non-progressive, but progressive, we were told, was no family tendency, no sign of disease. For boys, central precocious puberty, again, GnRH, you're thinking central precocious puberty. GnRH is, kind of first step in the release of follicular stimulating hormone, luteinizing hormone, which then goes to testosterone and estrogen. So central GnRH. Okay, so for boys, testes enlarge in central precocious puberty. For girls, you have an early increase in growth. Again, these are children who are below the normal age of puberty. So you have early breast development, increased size in the labia minora, and then maturational changes in the vaginal mucosa, and then you might have early onset pubic hair. All right. Then we have peripheral precocious puberty, which is dealing with the secretion of LH and FSH, right? So if GnRH is central, FSH and LH are peripheral, right? So that's how you can hopefully remember that. But GnRH independent puberty, most of the cases, again, this is just too much LH or FSH. So puberty development is often not completed, or patients are infertile. The example we were given was the McCune-Albright syndrome, which is early puberty, more often seen in women. Café-au-lait spots and bony fibrous dysplasia. You have the constitutive activation of the cells that are activated by luteinizing and follicular stimulating hormones. So you can imagine this would not be good in the granulosa cells of the ovaries. The result is you have an increase in production of estrogen. And again, what would that mean? Precocious puberty, right? And then in Leydig cells in the testes, increased production of testosterone because you're constantly activating those pathways. All right, and this is the mutation in the GNAS1 gene. How can you remember that? That is a great question. I do not know. But with this McCune-Albright syndrome, again, precocious peripheral puberty, you have bony fibrous dysplasia, right? Look at this. That does not look right. And then you have your café-au-lait spots, which we can translate as coffee on milk, so brown spots, which we would refer to as birthmarks a lot of the times. All right, what about delayed puberty? So delayed puberty is delayed gonad arc and secondary sexual characteristics, 2 or more standard deviations after normal. So for women, that's lacking breasts by age 13 or lacking menarche by 16. For boys, your testicles, scrotum, penis enlarge with puberty. So prepubertal testicular volume at age 14. We said that puberty for boys is 9 to 14, right? So this would be very late onset. All right, and then we have 3 categories of delayed puberty: GnRH dependent, pituitary dependent, and then gonad dependent, right? So GnRH pituitary is LH-FSH, and then gonad dependent is something wrong with testosterone, the production of testosterone and estrogen. All right, so we just rewrote the categories. GnRH dependent, basically what you would expect, GnRH secretions, some sort of issue with that. Couple of causes could be development of the hypothalamus didn't go correctly. You could have secondary causes, gonadal failure, defect in okay, so this is saying like after GnRH is not being produced, so like what happens as a result, less testosterone is going to be made. This is more common in men. We've already talked about Kallmann syndrome in the previous lecture, but HH Kallmann syndrome, hypogonadotropic hypogonadism. So this is saying low LH FSH results in low testosterone, low estrogen. All right, and then Kallmann syndrome is should be triggered by anosmia. So if they can't smell or very low smell, then you think Kallmann syndrome. If you're seeing again delayed puberty, and so this is a failure of the GnRH neurons to move from the olfactory bulb into the hypothalamus, decreased ability to secrete GnRH, failure to initiate puberty as a result of low testosterone, low estrogen. All right, so the other category is hypothalamic hypogonadism, acquired hypothalamic hypogonadism, so basically something wrong with the hypothalamus. All right, and then hypoosmia is reduced ability, right? Hypo means less, and anosmia means A, meaning no. All right, pituitary deficiency is the other cause of delayed puberty. So you'd think that, you're not getting enough LH or FSH. There could be a couple of reasons for this. One is, something wrong with your receptor for GnRH. You could have something wrong with your FSH or LH, such that it's not going to do what it's supposed to, right? It needs to be the right shape to bind. We know that FSH and LH are glycoproteins with two subunits, an alpha subunit and a beta subunit. It's the beta subunits that's different. So if there's something wrong with the beta subunit, then these guys aren't going to work. And then something wrong with the development of the puberty would also cause a puberty deficiency. Gonadal deficiency is testosterone, estrogen is low. And this could be due to sexual chromosome abnormality and therefore aberrant differentiation of the gonads. This is called gonadal dysgenesis. Haploinsufficiency for the X chromosome is called Turner syndrome, which is deletions, defined by deletions or arrangements of the X chromosome. And so Turner syndrome, something wrong with your X chromosome. Infantilism, so just never forming the secondary sexual characteristics. Congenital webbed neck looks like this. It's another situation for Turner syndrome. And then cubitus valgus, which you can see here is your arm is kind of splayed off its axis. All right, result of lack of production of testosterone or estrogen, again, also could be due to absence or injury of the gonads. Well, you don't have any negative feedback of the testosterone and estrogen, so you're going to have elevated gonadotropins, so hypergonadotropism. All right, so people with something wrong with their X chromosome with delayed puberty, example is, majority of women will not enter puberty, right? There's no lack of estrogen, and we were told they have normal verbal abilities, but they have specific deficits in visual spatial processing, motor function, nonverbal memory, and then we think they're associated with deletions on the X chromosome. You can diagnose this with prenatal diagnosis via ultrasounds or doing a chromosome test. All right, you can have growth deficiency, and you can treat with growth hormone, and then estrogen can be given to induce puberty as a treatment. All right, so then we have menopause. So we said as you get older, you are going to have an increase in LH and FSH. And why is that the case? Well, our answer is going to be with our gonadal deficiencies. So basically, as women age, you're going to have a change in the length of the menstrual cycle, which is going to be our first hint something's going on. And as early as age 35, FSH levels will start to rise. Why would that be the case? Well, as you are getting older, you have more and more follicles that are dying off. You have less and less, right? You're born with like millions, and then you end up with, I think at the start of puberty, 400,000 or so is what we were told. And then only about 400 of those over the course of your life will ovulate. But less and less follicles, and less follicles means less estrogen is being produced. And so less estrogen, less feedback, your FSH levels and LH levels are going to rise as you get older. All right, and so this is defined by different stages. We have the perimenopausal stage. So starting off with changes in variation of the menstrual cycles, menstrual cycle periods of greater than 7 days, followed by a longer interval of greater than 60 days cause menopausal transition. And this can last 1 to 3 years, marked by loss of estrogen, less granulosa cells, because you're having less follicles. As a result of less granulosa cells, less estrogen, less inhibins, less progesterones, less negative feedback. So FSH, LH levels rise. And then we have another indicator of this, which is anti-Müllerian hormone is going to decrease. And then the net result of menopause is a decrease in reproductive success. You can overcome this with in vitro fertilization. So what does that mean? Well, in vivo is in the body, right? In vitro is outside of the body. So in vitro fertilization means fertilization of an egg outside of the body. And so, what does IVF mean in vitro fertilization? You are going to stimulate the ovary to mature some oocytes. Then you're going to treat those oocytes. Then outside of the body, you're going to fertilize them. And then one of two things will happen. So you're fertilizing. You can freeze those for later, years later, or you can use them now. But basically, you get treat with estrogen, or follicular stimulating hormone, and luteinizing hormone to cause ovulation. Take those eggs, then you're going to fertilize them outside of the body, and then you can implant them later on if need be. All right, but as you age, the quality of your follicles is decreasing, as we were told. All right, so what's going on? Here's a little chart of, we have decrease in follicles, as a result, decrease in inhibin, decrease in estrogen, less negative feedback, increase in LH, FSH, and great. And then we have our testosterone production is continuing. So yeah, not too much there. For men, we have adrenopause, which is consequence of aging. Basically, your Leydig cell production is going to decrease. As a result of decrease in Leydig cells, you have a decrease in testosterone production. So sexual dysfunction, libido is going to go down, bone loss, fatigue increase, cognitive decline increase, an increase in mood changes. And then we also have the gonadotropin releasing hormone pulses are going to decrease with age, and that means less LH gets released, which we would define as andropause. All right, and less LH is going to result in less testosterone. And how could you ameliorate these effects? By giving a patient testosterone. All right, so that's it. That was quite a bit, but good job, guys. That was lecture 13 review, and I might do lecture 14. I think we might rely on the fillables for that one, but good job, and good luck.